So I'm just hoping that this is a sign of better times ahead of us, where we will all be traveling. So this is going to focus on not the returning traveler who comes back sick, but more on the pre-travel consultation visit. And as if you were not aware before, we do now have a travel clinic here on Morningside. So this is the overview of the talk. I'll just briefly mention the epidemiology, some general recommendations, and touch on the traveler diseases, diarrhea, vector and animal bite prevention, as well as immunization and other travel recommendations. I have nothing to disclose. These are old numbers, but they put things a little bit into perspective. So when we look at travelers' health risk, out of 100,000, 50,000, about half of them will have developed some problems, some serious, some less so serious. And out of those, about one will die. And these numbers actually still hold true, because we do have an ongoing monitoring system, which is called the GeoSentinel data. I don't know, you may or may not be familiar with it. This is a global sentinel surveillance network, which about 54, there may be a few more now, globally dispersed physician-based travel and tropical medicine clinics that have been chosen for this ongoing surveillance. And they're based on both the places that have training in travel and tropical medicine. And when they looked at the data from 2007 to 2011, they found 42,000, a little over 42,000 ill returned travelers. And what were they ill with? So GI complaints are common, about a third. Fevers, and then rash. So about 30, and rash a little less. Where do they get ill? Most of them actually get ill in Southeast Asia and Central Asia, followed by Sub-Saharan African. And that possibly more reflects more where where travelers are going. But when we look at that, in this surveillance data, only 40% of them had a pre-travel visit. So therefore, overall, even though 20 to 64% of travelers report some illness during travel, only 20 to 80% of travelers seek pre-health consultations. And the group of travelers that is actually at a highest risk of developing morbidity during travel is what we call travelers visiting their friends and relatives, or VFRs. And they have the highest mobility because their perception is that they were born and raised in this country and they can go back. But the truth is that for many of these infections in particular, malaria is one of them, typhoid is another, you lose your protection. With years, you do gain some partial protection if you live in the country with ongoing exposure. However, if you're an expatriate and you get out of Africa, for example, for malaria, you lose that protection in 3 years. So this is a particular group of concern if they're going back. So always ask, when was the last time you traveled back? So what travel consultation is all about is this structured approach. And this is from a publication in the New England from 2016. I do recommend it. If there's one paper that you want to read after this talk, this would be the paper to pull up and read. It's a very nice and thorough description of what a pre-travel consultation should be. So what should it be? You have to do a risk assessment, meaning both the medical history of the traveler, prior experience. Itinerary is super important, as I will mention, talk more about, type of accommodation, and so on and so forth. Then you go to the interventions that you should be providing in the office, and that's obviously the immunizations, malaria, chemoprophylaxis if indicated, and then discuss travelers' diarrhea. And then there is the focused education before the trip, also depending on the type and type of travel and destination. And we'll go over that a little bit. So in some cases, you will focus your discussion more on vector-borne illnesses. In other cases, more on altitude illness and so on and so forth. So what are the medical issues? So there's a lot of age-specific issues, and just before COVID, you know, a lot of geriatric population is actually traveling. So you need to be very careful about obtaining a thorough past medical history, underlying illnesses, immunosuppression. That also impacts the vaccines that you may or may not give. You do the regular thing, just like it's really just like taking an H&P. With a little special focus on vaccine and what underlying condition will affect your ability to vaccinate or not vaccinate. It's more of a review to find out what's contraindicated. And just to mention a few things that we do need to keep in mind. So allergies, what vaccines can you use? Well, if you're allergic to eggs, you should use the yellow fever vaccine with caution. And I emphasize, some of the flu vaccine were raised in egg-based media, not all of them. So you should know which vaccine does this clinic have. Always think about, and this is now very, this has come up again and again and again with the mRNA COVID vaccines. What other excipients are in vaccines? You don't have to know this, you don't have to learn it. Just check this immunofacts. It's a very thorough list of anything that is or is not included in a vaccine and what should be avoided. And yeah, and then medications. Again, medications and allergies. If a traveler is allergic to sulfa, for example, you should stay away from acetazolamide, which is Diamox, which is used for high altitude sickness, and you should stay away from Fansidar. Always check about antibiotic allergies, particularly quinolones, because that's what we tend to use for the diarrhea. And then chrysanthemums. I've never actually met a person who's allergic to chrysanthemums, but there is a cross allergy between that and permethrin. Then you look into interactions. You look into drug disease interactions. Keep in mind that PPIs or H2 blockers can theoretically increase the risk of developing traveler's diarrhea. And I always point this out because I have seen minocycline used for malaria. It lacks a proven protection for malaria. Don't use it. And then there's a drug-drug interactions. This is nothing new to you guys. Antimicrobials can interfere with so the PO typhoid is a live vaccine, and typhoid is a Salmonella species. So if a patient is on antibiotics, they should not be taking it with the typhoid. It will prevent the efficacy of the vaccine. Bismuth subsalicylates can bind quinolones. That's another thing to let patients know. And obviously warfarin and any antibiotics can increase the anticoagulant effect, which can be important in your elderly patients traveling. I just listed a few of the precautions. Mefloquine now has a black boxed warning actually because of its psych effects, not just depression, but also hallucination and other neuropsychiatric complications. So really it should be avoided in travelers that have an underlying depression or in fact any other psych problems. Bph and scopolamine. Scopolamine is a strong anticholinergic agent. Obviously, it's meant to that's what its use is for, but it can augment urinary retention in patients with BPH. Something to keep in mind too. A few more of them, of these, a lot of patients with ulcerative colitis, if they develop traveler's diarrhea, it can trigger a bad bout of UC. And just to point out, they are not more likely to develop traveler's diarrhea, but they're more likely to have severe complications from the diarrhea. And pre-existing liver disease is an indication to vaccinate against hepatitis A and B. And in fact, we do recommend it unless patients don't want it, that all travel to all countries, at least for hepatitis, should be vaccinated for hepatitis A, because believe it or not, there are ongoing food outbreaks with Hep A all over the world. COPD and high altitude, that's something that keeps coming in and out. It's probably a risk for worse of developing high altitude. However, anybody, healthy, young and old, anybody can develop high altitude sickness. So, travel preparation, what do we talk about and what do we recommend? Well, we always talk about the travel health insurance, both for medical care, hospitalization, and most importantly for certain travelers that going into areas into rural areas for a prolonged time, the evacuation plan. It's really we don't recommend any one kind of insurance. We just let people be aware that there is something called a travel insurance, and particularly if, as I said, for certain kinds of travel, we recommend that. Be aware of how to obtain a medical care abroad. Look into where, if I do get sick, where do I get seen? And awareness of travel notices. And I'll show you where it's the cdc.gov webpage, which is actually the best for these travel notices. And I'll give you an example of it at the end of this talk. We always talk about hand washing and hygiene. Well, now COVID has sort of ingrained this the hand sanitizers use into all of us, so it's probably less of an issue to talk about. But pre-COVID, we always recommended people take that with them, especially on planes during travel, and also depending on where they are. Check airline regulations, and this is applicable today again, because with COVID, every airline seems to have a different recommendation and different requirements, actually. So, you know, make people aware of that they need to check those beforehand. And we also do urge people to have their PPD placed. This is just a list from the yellow book, actually, of what a travel emergency kit should have. I'm not going to go over this. This can it's pretty straightforward, and anybody can adjust this travel kit to their own personal needs and make sure that they have the medications with them and so on and so forth. So what are the infectious disease risks to the traveler? Again, it's going to depend on where they're going, what kind of travel, but this is just a list of them, and it's by far not there's a lot more, but these are the most common ones. And this is just a table. It's from Up to Date, actually. It's either from Up to Date or from the New England Journal. I should have put the reference. I'll add it. But it's what you are at risk of being exposed to depends on the geographic area that you're going to. And this is a nice table because in the first column here, it will give you literally just Caribbean, Central America, South Central Asia, and so on and so forth, and which tropical diseases are you at risk of getting. It's a little easier for all of us because many of these are mosquito-borne, like chikungunya, dengue, malaria, Zika. But know that, for example, dengue and chikungunya, that those two conditions are sometimes difficult to differentiate. Except that chikungunya has more of a joint involvement, whereas dengue more of a fever and headache involvement. But know that you will find that in Central America, but you will also find leptospirosis, histococci, and leishmaniasis, which causes Chagas disease, is a big problem in Central America, both in Peru and and that's the you can get that not just from the flies, from the feces of the flies, but also from some foods, because if a food is left out in the open, these flies can leave the organism in food. So that's something to keep in mind. If you go into South America, again, they're pretty similar. Zika, as you remember, a few years ago was a big problem. South Central Asia, dengue is a big problem. Again, enteric fever, malaria. It's primarily non-falciparum. I will go over that a little more, and so on and so forth. Just look it up. Once you know where your traveler is going, just look up, make sure you're not missing any of these. So malaria. Malaria is a big problem. In fact, it's the 5th cause of death from an infectious disease worldwide, after respiratory infection, HIV/AIDS, diarrheal diseases, and tuberculosis. So this is a big problem. In 2019, there were 229 million cases and 409,000 deaths. It's a huge morbidity in certain parts of the world. And which countries are you most likely to develop malaria? So there are about 35 countries, in most of them in sub-Saharan Africa, but also in Asia, and they account for the big majority, or almost 98% of global malaria deaths. Now that does not mean acquiring malaria. You're very likely to acquire malaria also in some parts of South America. But the deaths are mostly in these areas. Obviously, you get it from a mosquito bite. There are multiple. There are about 5 types now. Falciparum and vivax is the most common. And of those 5 types, it's the vivax and ovale that can stay dormant in liver, and that's important because the treatment option is a little different. Even though we're not going to talk about that, you need to add an agent like primaquine that gets rid of the liver hypnozoites if a patient comes back with malaria. Falciparum is the deadly one. It can result in recrudescence when parasites are incompletely eliminated, and infection can actually recur weeks to months later. So that can be a tricky one of the malaria types. So where is malaria? If you look at the world, red parts of the world is where malaria occurs throughout. So you can get malaria there whenever you go there, and it's ongoing. In the yellow areas, mostly here in Asia and in Brazil and some parts of South America, malaria transmission occurs only in some parts. And how do you know which parts? Well, that's where you go to the interactive pages on the CDC webpage, or the yellow book. It will give you a very detailed list of where you will find malaria, where not. For example, in Thailand, it's really just by the borders. It's not by there's no malaria in the islands, which are which a lot of the tourists go to. So look it up and treat accordingly. Now, we always need to keep in mind resistance. So falciparum, let me start by saying the following. The chloroquine, the only areas of the world that are left with chloroquine sensitive falciparum are these blue areas. So Central America and the Arabic Peninsula, and Egypt too. So that's the easiest thing to remember. This is a new phenomenon. Now that we stopped using chloroquine for so many years because of resistance, there are some sensitive areas popping back up, But for now, the safest thing for you to know is that the Arabic Peninsula and Central America, those are the only areas left with chloroquine sensitive falciparum. The black area is an area of note. So this is Vietnam, Laos, Cambodia, and parts of Burma, or the border of Burma and Thailand. That's an area where they have actually mefloquine resistant falciparum. So you can't use mefloquine. So any patient going to areas within, for example, Cambodia, like Angkor Wat is a very common destination, they should not be given mefloquine. And then the red areas is malarious areas where you have chloroquine resistance, but not necessarily mefloquine resistant. And as you can see, most of the areas in the world have chloroquine resistant falciparum. This is just a table not meant to be read. But this is the chemoprophylaxis treatment for against malaria. So now that you know where the patient is going, and now that you know whether or not there is a risk of getting malaria, now you can decide, is that destination A, chloroquine resistant, or B, chloroquine sensitive. So if it's resistant, you can use Malarone, mefloquine, doxy, or tafenoquine. So the difference between these and how you choose them is, one, the duration of treatment after you come back. Malarone and tafenoquine are the shortest. And the other thing that you try to decide is, do you want to take a weekly tablet or do you want to take a daily tablet? Which is easier? Which will you remember? And I've heard it all. Some people say I'm much more likely to remember the daily one than the weekly one, and vice versa. I mentioned it before, the mefloquine has a problem with psychiatric side effects and hallucinations. Doxy is a problem when you're going on a vacation because it makes your skin sensitive to sun. And you need to be very clear about that, because it really does make people get sunburns. And it can be tough on the stomach. It has a lot of GI side effects. Tafenoquine, remember, you need to check G6PD status, just like with Primaquine. Tafenoquine, you need to check that before. Sensitive, obviously, the only added agent to that is the chloroquine that can use, and that is a weekly medication. So again, just to be clear, you need the full itinerary for all of these reasons. You even need to know the stopovers, because there are some countries, for example, that will that for yellow fever, they will require yellow fever. They may or may not require yellow fever at the final destination. But even if you have a stopover, even without deplaning, if the plane just stops for a fuel or something in a country where yellow fever is endemic, they may require you to have the yellow fever vaccination at the end stop. So that's important. Styles of travel, accommodation, where are you sleeping? Are you sleeping in a hotel with air conditioning and no mosquitoes, or are you out there camping? And then activities, what kind of activities will you be engaging in? So these are the 3 R's of immunizations that we're now going to move on to. It's the routine ones, it's the required ones, and recommended. And the routine are just whatever routine vaccines that we do anyway. The required ones, that mostly applies to yellow fever, because the WHO does require yellow fever vaccination for certain countries, and I'll show you a map of that. And then there's a recommended one where patients can decline them, but that will depend on the geographic destination, activities, and underlying health. So what are the routine ones? I don't really need to go over this. This is all that you know. You already all know all of this. For travel specific and Tdap, remember that the pertussis part of Tdap is an important one. And adults who only got their childhood TDA you should strongly recommend a single dose of Tdap. Now for travel, we recommend Tdap vaccination every 5 years, even though it's every 10 years here. Influenza, nothing particular there. We always recommend it. And make sure you have the updated routine vaccines in older people. MMRs, what's so special about MMR for travel? Well, the problem is any traveler that's born in the US after 1956, he should either have, they should either show you a documentation of 2 doses or evidence of immunity. And this dose business is problematic because many persons that were born in the US before 97, they would never receive the vaccine. However, they're likely immune because they were exposed to it, measles. Persons born in the 70s have not had a second dose because that recommendation was only out there in 1990. So you have to be pretty accurate about vaccinations. And then there are all of these other vaccines that should be recommended depending on where they're going. As I mentioned before, Hep A really should be a travel vaccine for everyone, going anywhere. And Japanese encephalitis is only in the rice paddies in Japan and Southeast Asia. And that's very seasonal, so you have to look up at the season also. Meningococcal vaccine, nothing special for travel, except that Africa does have this meningococcal belt that we call, and anybody going to this belt should get the meningitis vaccine. And these are the yellow fever endemic zones. Most of these countries have a requirement for yellow fever vaccination documentation. But remember, it's not just the final destination, it's where the whole trip matters. This is a list that you should know because now there's more and more immunosuppressed patients out there, not just from transplant, but all of these rheumatologic patients on monoclonal antibodies, they are all at risk for different infections. So you should know which are the live vaccines which can cause harm. It's the intranasal flu vaccine, it's the oral polio, not the IM polio, MMR, obviously varicella, and the oral typhoid and the yellow typhoid. Well, the oral polio is not really available in this country, so you don't have to worry about that one. Traveler's diarrhea has a lot of names depending on where people get sick. It's literally over 3 unformed stools a day, but if it's associated with nausea, vomiting, abdominal cramps, or low-grade fever, you should treat. And most of the times we give patients a course of antibiotics. It's Cipro, except for Southeast Asia, you can no longer use Cipro. You need to use azithromycin for that, and that's because of resistance. In most cases, it's self-limiting, and this is just another classification. If you have diarrhea for 3 days with the symptoms, you should consider self-treating, and so on and so forth. If not, you should advise patients not to take the antibiotics. This is just a list of who needs a further workup. So if anybody who has bloody or mucus stools with cramping, a stool culture should be done because Campylobacter and Shigella are treated differently. And patients with upper GI symptoms like bloating, nausea, that's a reasonable reason to have their stools examined for Giardia, Cyclospora, and Isospora. This is just a little bit of the same. It's pretty much your common sense. If they're ill, they should be taken to the hospital. So what about food recommendation? Bottom line is boil it, peel it, cook it, or forget it. So that's the bottom line. So that means you should eat well-cooked meat, vegetables, and other foods. Freshly boiled foods that are served hot also are safe. breads, obviously, nuts if you can peel it, and canned food. So what's not okay to eat and what travelers should avoid is uncooked food, unpasteurized dairy products, salsas, because that stands, and anything that's out in the open for a prolonged time. Water precautions, bottom line, boiled water. Do not, be careful that the seal is intact on bottled water, because they have been known to refill it with tap water, which in many parts of the world is just not safe. You should avoid ice cubes also, because freezing water does not necessarily kill the organisms. And diarrhea treatment, as I mentioned before, we use the quinolones for 3 days, except for Southeast Asia, you use azithromycin. This is just a slide to remind you that there's a lot of bloodborne and STD precautions that can happen during travel. And depending on the traveler and the nature of the travel, you should discuss that with certain kinds of travelers. For example, healthcare workers going to Africa to do surgery, we often recommend they take HIV PrEP with them, and so on and so forth. So it's very dependent on where you're going and what you're doing. And then for example, vector precautions, that's very, very important, because as I mentioned before from the table, most of these are mosquito or even tick-borne. So covering your skin is important. Insect repellent with at least 28% DEET is what works the best. And then we do recommend people treat their outer clothes with permethrin. Permethrin kills ticks on contact and is a very good mosquito repellent. It's either as a kit for your washing machine, as a spray, and some of the sports stores also sell these clothes pre-treated. You should use insect screen, and that all, depending on where you're sleeping, and so on and so forth. Insecticides for indoors, insecticides for outdoors, and then inspection of skin for ticks. These are just some of the environmental precautions that we do mention, again, depending on where you're going. Patients that are going to hike the Kilimanjaro, they should have some Diamox or acetazolamide with them. Sun protection is an obvious one. Altitude, so high altitude, I mentioned that already. And then water recreation. There are a lot of accidents that can happen, and schisto and leptospirosis is a risk there. Animal precautions, so rabies vaccine, we only recommend that these days for if you're going for a prolonged time in areas like aid workers, in areas where there is no help, very few medical facilities, and you're going to be working directly with wild animals. So we're also mentioning, it's always worth mentioning that patients that are coming back, it's reasonable to have a post-travel checkup, particularly if you're going to places like India and areas where tuberculosis is prevalent. So just mention that, and then post-travel care is always important. Injury and crime, again, that can or cannot be a discussion depending on the kind of travel and traveler. And I will finish off with these resources here. If you are advising a traveler, go to the cdc.gov travel for the malaria areas. The WHO also has a very nice web page with good resources, and then the state departments have their own. International Society of Travel Medicine, that's where you get the nitty-gritty, and then the Yellow Book is a very good handy resource, very easy to look up. So I would say that the Yellow Book along with the CDC webpage are probably the easiest. And this is why I like the cdc.gov, and this, I just took a picture of it yesterday. It gives you a warning It gives you areas of warning. For example, if it's in the red here, you should know about this. So here, these are countries that have things happening that you shouldn't be going there. For example, now in Haiti, the the earthquake that was there recently has made their drinking water um, with that has resulted in limited access to electricity, drinking water, and even food supply. So, you know, unless you unnecessary travel should not happen. Same applies for Venezuela. The infrastructure there is just not, it's just not stable. And then there are these volcanic eruptions in these areas that you see there, but also in the Canary Island in Spain this week. I'm surprised they didn't add that yet, because I don't know if you saw it. It's crazy. It's wiping out the whole city there. So this is why it's always good before a travel clinic, just check the CDC. Let's see what's going on, because sometimes things happen you may or may not have seen it in the news. And then there are the other alert levels, which for me is very useful, because polio, for one, they keep changing the recommendation for polio vaccines, especially in African countries. So it's always good to get your real updates there. And that's it. I don't even know. Yeah.
Thank you so much,